I think, well, when I started doing them, I will say most of my patients were in their 30s, mid 30s. They started to have heavy bleeding and they wanted something taken care of, but they weren't really ready to have major surgery. So usually it's the younger woman who has horrible bleeding or heavy bleeding to the point where, she has to change tampons or pads every hour, every 2 hours. And she can't even go to work some days, things like that. So it's a good procedure for that if she doesn't have the time to take off for recovery from a major surgery. And then probably the other group is the woman who is very, very close to menopause, where she just needs a year or so of decreased bleeding to get her to the point where she might be menopausal. At that point, she'll naturally stop bleeding. So those are probably the two sectors that we find that benefit the most from it. The difficulty with ablations is that, and there's a lot of discussion about how do you manage a woman who has quote unquote abnormal bleeding after having an ablation. The nice thing or the thing that we typically will do prior to an ablation is we'll do an endometrial biopsy. We'll get a sample of that lining to verify to some degree that there's no evidence of cancer. And if that's negative, then we can move forward with whichever procedure we decide, be it ablation or hysterectomy. Well, once you've done the ablation, you've scarred that cavity down. So many times you can't get into the cavity, you can't see the landmarks that you have, and as a result, you really can't evaluate that and say, okay, I can get the biopsy and say, yes, it's okay, or no, it's not. So that's where the difficulty comes after the ablations. If a woman has quote unquote abnormal bleeding after that, then that's a time that's a difficult one for us to evaluate for her and give her some reassurance that this is going to be fine, which then tends to lead us to hysterectomy.